Okay, so we're moving on to the case study, and this is always my favorite part. I'm always so pleased when they ask if I'll participate and help out with this portion of the programming, because for me, as a provider, really gives an opportunity to kind of pull everything together that we've learned over the last couple of days and try to apply it in a situation that we believe is pretty real. So, although I have to say, I don't know about the rest of you, but we have a locked or secured 10-bed brain injury unit, and I have been walking around Baltimore like this, watching the scooters, thinking, oh my God, I want to walk around with a sandwich board saying, where is your helmet? So next time we'll do a case study on maybe a brain-injured person who's scootering. As my mother used to say, it's all in good fun till someone loses an eye, right? Yeah. Okay, so here are the acronyms for the presentation, as usual. And so the objective really is to just take the information that we've been provided over the last couple of days and apply it in a clinical situation. And so in your packets, if you're here in the room, in your packets, there should be two documents that we're going to ask you to pull out. One is the case study, they're number 11. It's a case study, the big text. And then there's also a coding sheet. And for those folks who are live streaming and got their information off the hub, that would be document 11A and 11B. So let's take a few minutes to meet Mr. K. And he is a 76-year-old male, admitted to acute care hospital on June 10th with congestive heart failure and a right hip pain following a fall. His admission diagnosis is a right proximal femoral fracture. He had an exacerbation of his congestive heart failure and a deep tissue injury on the right lateral malleolus. His past medical history includes some hypertension, the heart failure, and depression. Poor Mr. K underwent a total hip arthroplasty on June 11th to repair that femoral fracture we talked about, requiring some post-operative diuresis and some supplemental oxygen due to his heart failure. His post-operative status stabilized, but progress with therapy was a little slow. He was transferred to your inpatient rehab facility on June 20th for ongoing respiratory and physical rehabilitation. So what we're going to ask you to do, because you are such a good group at working in groups, there's a lot of chatter going on at the tables and everything. We're going to ask you to work in groups at your table and go through the coding for this portion. We're going to give you about 35-40 minutes because the case study takes a few minutes to read, and then we want you to have ample time to be able to do that. What we've decided to do is not have you do the full quality measures, but we did a subset of each of the sections. So we're going to kind of pull in different areas. So we're going to ask you to code items GG 0100, 110, 130, and 170. And then we're going to have you code M0210 and 0300. We're going to do the drug regimen review, the N2001 and 2003 for admission. And then we're going to ask you to do the discharge assessment related to GG0130 and 170, the M0210, and the M0300, and then the final drug regimen review, N2005. So it gives you kind of a good cross-section of the different items. So about 35 minutes from now is about, I'm looking to my friends, about 2:40. So I'll kind of roam around the room, see if you have any questions, but we'll take that time. If you want to get up and stretch in your room or back at the office, you can feel free to do that. And then we'll reconvene and go over all the responses so that you're sure you leave here today with a fully completed case study. So what we'll do is we'll go through all the answers, and that way you'll have them and can bring them back with you when you leave today. Okay, so we're going to start and we'll go through the assessment, admission assessment, GG items. So, yep. Yes, yeah. So some of you may have discovered that that the answer sheet is in your packets. Yeah. And that is information you can bring back with you, but we'd like to go through the responses now as well, and just sort of share and go over some of the rationale verbally. But thank you. So we're going to do GG 0-100 first, so prior level of functioning. And so we're going to talk about self-care. So for self-care, right, we're going to code the patient's need for assistance with bathing and dressing, using the toilet, or eating prior to the current illness, exacerbation, or injury. Manisha went over this with us really well the other day. So the correct code for that is 3. Everybody looking okay? So for indoor mobility, here we want to code the patient's need for assistance walking from room to room, with or without a device such as a cane, crutch, or walker, prior to the current illness. And the correct code there is, oops, I'm sorry. I should have gone over the rationale. I apologize. So for the first self-care, is 3, independent. Mr. K was independent with the self-care. I'm sorry. Jumping ahead. So now we'll talk about the indoor mobility. And the correct response for that is also 3. And the rationale for that is that Mr. K, prior to his hip fracture, walked himself indoor surfaces with that rollator walker. So prior functional level for stairs. Here we want to code the patient's need for assistance with internal or external stairs, with or without a device. The correct code for this is 2. And the rationale for that is Mr. K required standby assistance from his daughter to climb the stairs to that second level. Remember his daughter Ruth? He used the handrail and then she kind of walked up behind him. And I don't know about you, but I wish all my patients had a daughter like Ruth. Okay, D, functional cognition. Here we want to code the patient's need for assistance with planning regular tasks such as shopping, remembering to take medications prior to the current illness or injury. And the correct response there is 3. And the rationale for that is that Mr. K was independent with all his functional cognition tasks prior to the hip fracture. He was able to manage, they mentioned his medications, and he paid his bills and assisted with the grocery shopping. So now we're going to talk about prior functioning, the prior device use. And here we want to check and indicate the devices and aids that were used by the patient. And how many people just love that video? Wasn't that a great video where we saw yesterday where they went over the devices? I love that video. Okay, so here we want to check all that applies. And in this case, we know that he used that rollator walker and also the wheelchair. So he used that rollator walker indoors and then used that manual wheelchair, and I think it mentioned he wheeled out to his mailbox to get the mail, and also I think over to see his neighbor as well, which is nice. Okay, so 0-130, self-care. And here I'll give you the answer for both the admission performance code and also what the goal should be. So for eating, Manisha did a great job of making sure that we understood the definition for each of these items so that we're all coding the same. And it's the ability to use suitable utensils to bring food and or liquid to the mouth and swallow food and or liquid once the meal has been placed in front of the patient. So the correct responses here are, so for the admission performance, our assessment is 05. And the occupational therapist is expecting that he'll be independent at discharge. Someone up front here is all excited. She got the right answer there. Good for you. All right, for oral hygiene, it's the ability to use suitable items to clean teeth, dentures if that's what the patient has. and the ability to insert and remove those dentures into the mouth and then manage those dentures, and then rinsing and use of any of equipment. Oh, I keep doing this. I'm so sorry. I keep giving you my own rationale, and I forget that the slide has a rationale. I'm so sorry. So here's the rationale for eating. He feeds himself with setup from a certified nursing assistant. And again, as I mentioned, the occupational therapist is anticipating that he'll be independent at discharge. And so for oral hygiene, the admission code is an 04, and the oral hygiene goal is 06, again, independent. Look at me, I'm learning. The rationale for this item here is that the CNA did provide some supervision as he brushed his teeth, right? Remember that? And stand by for safety. But we do anticipate that Mr. K will be able to do this independently upon discharge. So for toileting hygiene, and that's the ability to maintain perineal hygiene, adjust clothing before and after voiding or having a bowel movement. If managing an ostomy, it includes wiping the opening, but not necessarily managing the device itself. And the correct code here for admission performance is 04. And for discharge, we're anticipating that he'll be independent with that activity. And the coding rationale for this is that he did require supervision or touching assistance, steadying assistance from just the one helper while he was standing and adjusting his underwear and slacks. And again, the OT is predicting that he'll be able to do this. And I don't know about you guys, but where I work with the PPS coordinators and the admission nurses and the case managers, and someone's ability to do their own toileting is a good predictor about a community discharge, right? Families are willing to do a lot of things, but when it comes to some personal care like this, that can sometimes be that defining moment. So this is making me feel good about Mr. King being able to be discharged to the community. Okay, so we're going to talk about a subset of GG 0170, the mobility. And again, we'll do the code for admission and then the goal. And so for toilet transfer, and that's the ability to get on and off the toilet or commode, and the correct responses. So for the admission performance, the correct code would be 03, and the discharge goal is 06. And the rationale for that is here, and that is that Mr. K did require the assistance of just one helper, providing less than half of the effort to transfer to the toilet. But again, our very optimistic occupational therapist is feeling as though she's going to be, or he's going to be able to get him to be able to do that independently. So walk 10 feet. Ann went over this with us, and walk 10 feet. Once we're standing, the ability to walk at least 10 feet in a room, corridor, or similar space. And the correct response or codes for this are 03 for admission and 04 for the discharge goal. And the rationale for that is that Mr. K was able to walk 10 feet with the rollator walker. He did need the help of that one helper, providing less than half the effort. He did require some steadying as he began to walk, and then progressively required some of his weight to be supported at least 3 feet of the 10 feet walk. But again, we're hoping that he'll be able to do walk 10 feet at supervision or touching assistance at discharge. So walk 50 feet with 2 turns. So once standing, the ability to walk at least 50 feet and make 2 turns. And I have to say, I'm gonna, when I go back next week, I wanna use Ann's comments about how many times patients turn. I hadn't really thought about it until she described it, and when I think of our patients, how many times they have to turn into the bathroom, when they're leaving to go to the gym they turn, when they come back they turn, in the gym they turn. So oftentimes the therapist will ask me, I don't understand why we're doing this. So now, thank you, Ann. It's a great to be able to bring that information back. So for the admission performance, we're going to say 88. And for our discharge goal, we're saying 04 are the correct responses. And the rationale for that is this. So the activity was not attempted due to medical condition or safety. And so because he was fatigued, remember he had the heart failure and some of those additional conditions in addition to his hip fracture, it was not attempted on admission, but the therapist is feeling as though by discharge we'll be able to get him to a supervision or steadying assistance. The walk 150 feet, so once standing, the ability to walk at least 150 feet in a corridor or similar space. And here the codes are 09 and 09. That can be a tricky one, so we'll go over the rationale. I see people nodding their heads though, yes, so I'm thinking you're comfortable with this. But the activity was not attempted during the 3-day assessment period. And remember that Mr. K, prior to admission, was not walking 150 feet, even before the hip fracture. So that's why 09. And the physical therapist does not believe that by discharge we're going to be able to get him to do even better than he was doing before he fractured his hip. So the goal is 09 there as well. Okay, does the patient use a wheelchair or scooter? And here we just answer yes or no. And the answer is yes, the patient does use a wheelchair. Wheel 50 feet with 2 turns. Once seated in the wheelchair, the ability to wheel at least 50 feet and make the 2 turns. So the correct responses here are 02 and a goal of 06. And the rationale is here. Once seated in his wheelchair, remember Mr. K could only propel himself about 20 feet and then required some assistance from a helper to straighten himself after a turn. He then required the helper to propel the wheelchair the remaining 30 feet to complete the activity. And at discharge, however, the physical therapist feels that the patient will be able to do the 50 feet in his manual wheelchair. And remember, Ian talked a little bit about this before, about, we can assist patients in wheeling, but we can't make them walk. So she talked about that yesterday. So indicate the type of wheelchair that's used, whether it's manual or motorized. And in this particular case, Mr. K was using a manual wheelchair. And the wheel 150 feet. So once seated in the wheelchair and or scooter, the ability to wheel 150 feet in a corridor or similar space. And the correct response for this is 0202. So the goal, the admission assessment is a code 2, and our physical therapist is anticipating that that will be what the patient will be at discharge. So the rationale is here, and again, it's similar to the one earlier, that after propelling himself 20 feet, he becomes fatigued, and a helper must propel him the remaining 130 feet to add up to the 150. And although the helper contributed more than half the effort to complete the activity, Mr. K did do some of it, and so he's not dependent. He would be an 02. However, if the helper had done all of the effort to complete the activity, or if it took 2 helpers to complete the activity, then a code 1 would have been used. And again, as far as the discharge goal, based on his prior level of function, the physical therapist is really anticipating he's going to be able to do about the 70 feet he could do before admission, and then the helper would have to do the remaining. And remember, I think it was his daughter would help him do that distance so that he could go visit his neighbor. Gotta love Ruth. And then the last question is, indicate the type of wheelchair or scooter used to score this, and it's a 1, a manual wheelchair. How are people feeling about these so far? I see heads nodding in the room, hopefully also back live streaming. But it looks like people are feeling pretty comfortable. Okay, now we're going to do section M, skin. These are always fun to do. So what I'll do with these is, there's a Slido question. Does this patient have one or more unhealed pressure ulcers or injuries? Just so you don't relax, we keep you alert with the Slido. It helps us to know that the people back in their offices are participating. So we appreciate everyone participating. So it looks like we have some people weighing in. And it looks like you're feeling pretty confident with your answers. So we'll go ahead and move on to the correct answer. And the correct answer is B, yes. And that's because upon admission to the IRF, remember Mr. K had a pressure ulcer on his coccyx and a deep tissue injury on his lateral malleolus. Okay, now we'll go through the items here. And what I'll do is we'll go through all the admission assessment items and we'll code those, and then I'll go over the rationale. So for M0300A1, the number of stage 1 pressure ulcers, the correct code is 0. There were none of those. For M0300B1, stage 2 pressure ulcers, the correct code is 0. The number of stage 3 pressure ulcers, which is M0300C1, the correct response is 0. The number of stage 4 pressure ulcers, the correct response is 1. Oh, good. I think Ann did a really nice job, I think, of explaining how that is. And M0300E1, the number of unstageable pressure ulcers and injuries due to non-removable dressing and devices is 0. The number of unstageable pressure ulcers due to coverage of wound bed by slough and or eschar, correctly coded is 0. And the number of unstageable pressure injuries presenting as deep tissue injuries, the correct code is 1. People are nodding, good. And the rationale for that is upon admission to the IRF, Mr. K had a pressure ulcer on his coccyx and a deep tissue injury to his right lateral malleolus. And to accurately stage these wounds, the nurse reviewed the history of the pressure ulcers in the patient's medical record. Very good. And just to further reiterate that, remember the patient had a stage 4, although it was assessed as a stage 3 on admission. What Ann reminded us is that we need to make sure that we review the medical record and identify the original injury, which is a stage 4 pressure ulcer. And the right ankle was assessed as a deep tissue injury. And we all know that we don't look at the surgical wounds aren't pressure ulcers as well, so that hip incision isn't included at all. Okay, admission assessment, the medications, section N. And we're going to start with a Slido question. So, based on the case study and your assessment of this situation, would you say, did a complete drug regimen review identify some potentially clinically significant medication issues? Okay, let's have the answer. It looks like everybody's in agreement. And the correct answer is yes, there were some issues found during that review. And remember, the pharmacist identified 2 different doses of the same medication to address mild pain. The combined dosage could have exceeded the maximum dosage for ibuprofen, and the pharmacist considered this a duplicative order and a clinically significant medication issue. Did the facility contact a physician and/or a physician designee by midnight of the next calendar day, complete the prescribed recommended actions in response to the identified potentially clinically significant medication issue? I got some responses coming in. And the correct answer is yes. So on the day of admission, the pharmacist did identify that issue. He contacted the physician, left a message, and then an hour later, the admitting physician returned the pharmacist's phone call to clarify and change the orders. And that evening, the charge nurse noted and implemented the change. I don't know about you guys, but we get a lot of those duplicative orders in that first 24 hours, or sometimes the pain medication overlaps, what's from mild to max, and, at least in Connecticut, that's out of the scope of practice for a nurse to decide which is the right. So we really like to get our doctors to give a pain scale for which medication. So I don't know if that's everywhere, but we spend a lot of time trying to educate our docs on that. Okay, so a subset of GG0130 self-care. And these are our discharge assessments. So already Mr. K is ready to go home. We've done a great job. His daughter Ruth has been trained. Everybody's feeling good. Okay, so for eating, again, the ability to use the utensils. You guys know the definition by now. I'm not going to read it to you again. But the correct discharge performance code should be 06, right, and independent. And at this point, he was able to open his containers, he used his utensils, he was able to feed himself without any assistance. And for oral hygiene, the correct discharge code should be also 06. I'm seeing heads nod, this is good. So he was able to brush his teeth and he completed all the oral hygiene tasks independently. So for toileting hygiene, let's hope I got my fingers crossed, he met his goal. He did, 06. And he was able to manage his own perineal hygiene and clothing without assistance. So nice job if this is at your rehab hospital. Okay, so a subset of GG0170 responses. Let's see how you did here for discharge. So for toilet transfer, we're going to say the correct code should be 06 for discharge. And that's he was able to complete this activity without any assistance. The walk 10 feet, once standing. The correct code here should be 04. And he was able to walk 10 feet with the rollator with some supervision from a helper. The use of the assistive device to complete the activity, should not affect your coding. But it's the fact that he walked the 10 feet with some supervision. And I think Ruth is going to do that for him. I know it. So walk 50 feet with 2 turns. So once standing, the ability to walk 50 feet and make those 2 turns. Correct discharge code would be 04. I see heads nodding. I'm feeling good. And that's because he was able to walk that 50 feet with 2 turns. He used that rollator walker we've been talking about and did have some contact guard assistance. Again, just to reiterate, the use of that device does not affect the coding now. And the last one, walk 150 feet. His discharge code is 09. This is one that kind of confuses people sometimes. And the activity was not attempted because Mr. K was not walking 150 feet before he came into the hospital. Does the patient use the wheelchair or scooter? We know that the answer to that is yes, right? Wheel 50 feet with the 2 turns. The correct discharge code for that should be 06. I see heads nodding still, so that's good. So he was able to wheel himself approximately the 60 feet and completed the 2 turns without any assistance. So he should be able to navigate his home, right? 60 feet is usually enough of a distance to be able to get through most homes. We usually look at like 40 feet is sort of the bare minimum. Indicate the type of wheelchair or scooter that was used. Again, it's a manual, right? Wheel 150 feet, once seated in the wheelchair, ability to do the 150 feet. The correct code here is 02. And so, as we said, he was able to wheel himself 60 feet. A helper was needed to propel the remaining distance to make up. So it was 90 feet to make up a total of 150 feet. The helper does more than half the effort to complete the activity. Indicate the type of wheelchair or scooter used. Again, manual. People are feeling good? Yeah? Oh, good. Good. I see heads. All right, skin. So the discharge skin, I think, is one of the harder ones. So we'll go through that. And again, we're going to do Slido first, but then I'll show you your answers before. So does the patient have 1 or more unhealed pressure ulcers? This is for discharge. We're coding him for discharge. People are weighing in, and everyone seems to be selecting the same thing, which is usually a good thing. So we'll go to the responses. We'll see what the correct answer is 1, or B, 1, yes. Great. So, at discharge, Mr. K had the 1 unstageable pressure ulcer on his right lateral malleolus. So, I'll go through the discharge assessment, but I think it's important to remind you of your answers ahead of time. Whenever I say that, I think of, what is that show, Family Feud, where Steve Harvey always reminds the second person in the action round what the first answers were. All right, so for discharge assessment, the number of stage 1 pressure ulcers, the correct code here is 0. The number of stage 2 pressure ulcers, the correct discharge code is 0. The number of these stage 2 pressure ulcers that were present upon admission is a skip, right? Remember, Ann taught us that. And the number of stage 3 pressure ulcers on admission is 0. The number of these stage 3 pressure ulcers that were present upon admission is skip. The number of stage 4 pressure ulcers, discharge code, is 0. People are nodding. This is good. And the number of these stage 4 pressure ulcers that were present upon admission is skip, right? Because remember Ann taught us, which I found very helpful. That's the other thing Ann Spinard this time taught us, to look at that discharge in and of itself and then worry about was it present on admission? Because sometimes I think clinicians want to try to look at what's there and try to relate it to the admission, and the better way to view it, I think, is to just sort of look at that snapshot in time. So I appreciate that suggestion. Okay, so for M0300E1, discharge assessment code is 0. The number of these unstageable ulcers due to non-removable dressing device is a skip. The number of unstageable pressure ulcers due to Sluffer-Eschar is 1. The number of these unstageable pressure ulcers due to Sluffer-Eschar that were present upon admission is 0. Oh, good. People are nodding. This is good. The number of unstageable pressure ulcers with deep tissue injury is 0. And the number of these unstageable pressure ulcers with deep tissue injury that were present upon admission is skip. And here's the rationale. So remember, he had an unstageable pressure ulcer due to slough and or eschar at the right lateral malleolus at discharge. The pressure ulcer that was identified as a DTI on admission. So during the stay, it was reclassified as a stage 4. However, at discharge, slough completely covered that pressure ulcer. Remember, Ian taught us that if we can't see it, we can't stage it. Therefore, it's considered not present on admission. Numerically staged pressure ulcers that become unstageable due to slough or eschar should not be coded as present on admission. The healing stage 4, pressure was observed at admission and is now closed. Good for you. You healed up that pressure ulcer. And medications, we only got a few slides left. I'm running out of time. Did the facility contact and complete the physician or physician designee prescribed recommended actions by midnight of the next calendar day each time a potentially significant medication issue was identified since admission? You guys are always one step ahead. You're already answering. In the interest of time, I think we'll move to the answer. And the correct answer is yes. And the rationale is the clinically significant medication issue identified by the pharmacist on admission was communicated. We know that. And then on day 5, there was a second medication issue, and the nurse was able to identify and get the orders changed by midnight. Okay, so you have your case studies and you have your answer sheets, so you can bring them back to your staff and use them for training purposes. For your action plans, if you want to record any information that you discovered while doing the case study, either pieces of information that you learned earlier in the day that really you felt once you applied the information in a case study scenario would be helpful. I don't know about you guys, but when we do any of the trainings, we always bring dessert or something. Last week we brought Klondike bars, and I'm telling you, people will do anything for a Klondike bar. They will come to any in-service you have if you announce you're having Klondike bars. So it's a small investment to get good attendance at one of your trainings. So I thank you very much. I've enjoyed getting to know you and wish you safe travels.